case is actually liquid biopsy, and only the liquid biopsy, but this patient must have very high tumor load, and you can really see even chromosomal abnormalities that we can really see numerous of these chromosomal abnormality on the liquid biopsy. That's very unusual, except in patients with high tumor load. Next slide. And what's really interesting, which I want to point out here, is CHEK2 mutations that detected in our liquid biopsy. It is shown on top in red, and as you can really see, the variant allele frequency is at 32.48%. At the same time, you can see all the other abnormality, including the PIK3CA. At the same time, you can really see a mutation called B2, which is another red pointed out genes. The important part of this, that by doing the plasma testing, we believe that the CHEK2 mutations is a germline abnormality because it is expressed at very high levels as compared with the other mutations. So this patient has a germline abnormalities for CHEK2, which is one of the DNA repair genes, and this might have, it is inherited abnormalities and might have some implication on the family histories as well as even the treatment of this patient. Next slide, please. And this is the final things, and we pointed out that the CHEK2 is inherited abnormalities, and the other findings can be helpful for Dr. Weintraub, like the PIK3CA for treatment, and the presence of the CHEK2 mutation always suggests PARP inhibitors as well, and there are additional mutation can be helpful for therapeutic implications. Dr. Weintraub?
Yeah, this is actually a good case because she's my patient, but Dr. Gutierrez treated her as well, as you'll hear. This 62-year-old woman who had an ER/PR positive, HER2 negative breast cancer, who we've been seeing since 2010, who was 6 years disease-free, and then in 2016 presented with bone metastatic disease. He was treated with aromatase inhibitors and a CDK4/6 inhibitor, palbociclib. She outgrew that. She developed liver metastatic disease, which was tissue biopsied, and because she had a high TMB at that time, I referred her to Dr. Gutierrez for immunotherapy trial back in 2017. She was treated with 2 different immunotherapy trials, including nivolumab, failed that in 1 year. And when we got her back, we did this liquid biopsy that you've so eloquently shown now. She's on IV chemotherapy now and doing very, very well, interestingly enough. But we utilized all the things you pointed out. She's had CDK4/6 inhibitors, and she's had immunotherapy because of her high TMB. What's interesting about this case is the liquid biopsy showed as much as the tissue biopsy, which means that she probably has a huge amount of tumor circulating in her blood.
Right, and are you doing anything regarding the inherited CHEK2?
No, not yet, but she certainly will be a candidate if I can get it for PARP inhibitors if she outgrows the current Abraxane chemotherapy she's on. So that was very helpful because we now know she has a germline mutation, which helps us a lot.